starting this session with all your.
Yeah, go ahead.
Yes, sir, sure, it's getting connected. Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor on this session. And I would like to invite today's moderator with his introduction, Dr. A.P. Misra, sir. Let me share some of the achievement of the sir. Sir has done MBBS, MD, Medicine, FICP, Senior Consultant and Head of International Medicine, Medior Kutub Hospital, Senior Consultant INT Medicine, Fortis Vasant Kunj Hospital, New Delhi. And for today's session, the topic is World TB Day. Let's make a world free of TB. Let me tell you overview of the topic before starting this session. The theme of World TB Day 2023, Yes, We Can End TB. Convey a message of hope that getting back on track to turn the tide against the TB epidemic. Tuberculosis is caused by Mycobacterium tuberculosis. Tuberculosis is a curable and preventable, and it is the 13th leading cause of death and the second leading infectious killer after COVID-19 as per the WHO. For the more details and invite the speaker, I would like to invite AP Misra sir to introduce the speaker. Over to you, sir. Kindly proceed from here.
So first talk shall be delivered by Professor Jayalakshmi, and she is working in Apollo, Mumbai. She is an avid researcher. She has won many awards. Her, if Dr. Jayashree, can you share with your screen your introductory slide? Hello, Dr. Jayashree, can you share your introductory slide?
I had already sent it. I'm not sure I can share it, but I can try.
No, you try. Okay, anyway, doesn't matter. She's an avid researcher, has won many awards, and as the moderator has already emphasized, Dr. Jayashree shall be speaking about the evolution of the tuberculosis treatment and what is the treatment of the MDR tuberculosis. It was really considered as a death sentence in the 19th century and in the earlier part of the 20th century, before Waxman discovered the streptomycin, and afterward many other drugs were discovered. However, India, we are having the unique distinction of having a large pool of the tuberculosis patient. In the large data of the WHO in 2020 has mentioned that we share almost 26% of the new cases occurring in the world are reported from the India, mainly because of the large population also, plus there are large number of the infected patients, large number remain undetected, and whosoever are getting the treatment, many of them are not getting the adequate treatment. So from where we started and where we are now, so I shall request Dr. Jayashree to start with her deliberations. Dr. Jayalakshmi, sorry.
Hello.
Yeah.
Are you able to hear me and see my screen?
Yeah. I can see you. We can see your screen.
Thank you so much, Dr. Mishra, for the very kind introduction. And it's my honor to speak today at platform of IGCP for the World TB Day. So TB is always very close to the heart for treatment in patients, for all the pulmonologists, all the internal medicine, and indeed all the doctors in India, because we see such a large number of TB patients. And it is very gratifying to see when the patients are being treated and when they improve. And at the same time, it is equally heartbreaking when it is an MDR TB or when it is a patient whom we are not able to cure, and to see a young patient dying of MDR TB or not improving. So that becomes really very heartbreaking, considering the large number of patients that we see. So today we will just go into the treatment of pulmonary tuberculosis, and then we will see how has been the evolution of pulmonary tuberculosis from the beginning, from the ages, and where we are today. So that will be the theme of my talk on evolving trends in the treatment of tuberculosis and MDR tuberculosis. So the theme of our World Tuberculosis Day today is, yes, we can end TB. Even in India, we have
Ma'am, sorry to interrupt, ma'am. Can you
Yeah.
please put it on the full screen, ma'am, on the slideshow?
Yeah, 1 minute. Huh?
Fine, ma'am, fine.
So, we even have made a pledge to end TB by 2025 as per our PM Narendra Modi ji. Although we are not on track to end PM by 2025, we are definitely on track to reduce the incidence of tuberculosis, and the big breakthroughs in the horizon are seen in the field of MDR TB. And pre-XDR TB, where there are new regimens. Like for so many years, last 20, 30 years, we would say that there is no new treatment available for tuberculosis. But now there is a new treatments which are available, newer drugs are available, newer regimens are available, shorter regimens are available, injectables have been done away with. So we are actually looking at a new time in the treatment of tuberculosis. So this is my background, and we had earlier, when I was in D.Y. Patil Hospital as a professor in HOD, we had set up our DRTB center as well over there. And we were part of the RNTCP, it was called at that time, program, where we used to have all the facilities for diagnosis and treatment of MDR TB as well. So it is an ancient disease. It was identified as spinal TB even in Egyptian mummies. So this has been confirmed by PCR tests done today, that even the mummies of those times had bone tuberculosis, and this could be documented. We know that tuberculosis was called as consumption, and it was very big killer in the industrial era in the European countries and in the United Kingdom as well. Also called as a white plague, and it was a death sentence, and the only treatment available was the sanatorium treatment. So 1865, TB was infectious, was proved by Jean-Antoine Villemin. 1882, Robert Koch discovered M. tuberculosis on this day, that is March 24th. That is why today is being celebrated, or rather commemorated, as a World TB Day. I would not like to use the word celebrated for this. And in 1882, we had the discovery. So more than 100 and almost 150 years have passed after the discovery of M. tuberculosis. And 1943 was the first drug, that is streptomycin. That time only one drug was available. Sanatorium treatment would be given. Many patients were on waiting list to start these drugs. And although the drug was started with great fanfare, at the end of a year or two, many patients became resistant to streptomycin, relapsed with the disease. Those days, over a 5-year period, the survival used to be only about 20% for patients diagnosed with tuberculosis. In 1943 to 1952, INH and PAS as well came out. Then pyrazinamide came out in the 1970s, and slowly the TB cases started declining. So, however, from 1995 to 2014, we see that the number of new infections diagnosed went on increasing. 2015, there was a scary discovery that 9% of the resistant TB strains were there, which were untreatable. So from the ancient times, we see how the TB has developed. We were able to diagnose the disease. There were newer methods of diagnosis. In 2012, the Gene Expert Ultra molecular test was launched in 2010. Gene Expert became one of the easy ways and quick ways to diagnose accurately tuberculosis. In 2012, the MDR TB regimen started coming out. So now in 2018, latent TB treatment started, NTB strategy was announced, and newer drugs have been now approved for highly drug-resistant tuberculosis. So what is next? In India as well, from 1500 BC, we know about the disease which was called Kshay Rog or Sosha, it used to be called. It was also said that the moon god was one of the first victims of the disease. It was also called Rajakshma or king's disease because many kings as well suffered from the disease. So this was the earliest form of treatment, was the sanatorium treatment which the British had established in our country, though they were few in number and could cater only to few people. So 1993, WHO made a global emergency call for stop tuberculosis. In 1997, we had the revised National Tuberculosis Control Program. 2005, we had the revised National Tuberculosis Program. Now it is called as the NTEP. Which is now called NTEP. 2016-17, earlier there was this thrice a week regimens, then we were back to the daily regimen in 16-17. Our NTCP was renamed as NTEP in 2020. And so this is the cumulative performance from the rollout. So the number of MDR-TB diagnosed is around 3 lakhs, put on treatment, slightly less number than the number diagnosed. XDR-TB 14,000, isoniazid resistant tuberculosis 38,000. So these were the numbers of TB diagnosed, put on treatment. Although the results of MDR-TB treatment used to be about 50 to 60% at best. For the drug-resistant TB, that is XDR-TB, the results survival was about, or cure rates was about 25% at best. So this was a bleak picture. Although the primary TB, which was drug sensitive, there was a good rate. If the patient took the treatment properly, there used to be 90 to 95% of cured patients, cure rates. But on the ground, the treatment adherence was not that good. So many patients were not able to access the treatment, even though it was available free in all the health centers. So these were all the challenges which were there. The DRTB process was enlarged. Then we have the National Strategic Plan from 2017 to 25 for ending tuberculosis, where TrueNat was introduced for diagnosis, nationwide coverage for delaminid availability for shorter MDR-TB regimen with bedaquiline has been planned. So this bedaquiline and delaminid has been now introduced and bedaquiline is already made available nationwide. Although all the patients don't get bedaquiline, XDR, extrapulmonary tuberculosis, like abdominal TB, neuro TB, these are still excluded from till recently excluded from the purview of getting bedaquiline. So they would still get the long acting regimen, the newer long oral regimen. So then we come to the point of a TPT, that is preventive treatment, tuberculosis preventive treatment. So tuberculosis preventive treatment was always there for HIV patients, but now it has been extended to cover the patients who are the contacts for the pulmonary TB. Patients who are sputum positive pulmonary TB patients, their contacts have also been, so basically the adults and children, not only children. Earlier children also used to get the preventive treatment, but now it has been extended for adults to take. So which have been the regimens approved? There is isoniazid and rifampicin, that is the 3 HP regimen for 3 months, once weekly regimen. So this combination is not available everywhere, but various drug companies have set in to start making this combination available so that we can give a once weekly 3-month regimen with only total of 12 doses for the tuberculosis preventive treatment. Rifampicin alone for 4 months, isoniazid and rifampicin for 3 months in a daily regimen, isoniazid alone for 6 months to 9 months, whether even daily or twice weekly, has both been approved for the tuberculosis preventive treatment. So while we are giving tuberculosis preventive treatment, we must make sure whether the patient is in the group of HIV positive or not, whether the patient is symptomatic. We have to rule out active tuberculosis. And only once active tuberculosis has been evaluated and ruled out can the patient become eligible for getting the preventive treatment. For this, we need to ask for the symptoms, we need to do the chest X-ray chest, and we need to rule out to check whether any preventive treatment is contraindicated in these patients. So active TB disease, acute or chronic hepatitis, if the patient is on any other hepatotoxic medication such as nevirapine, taking alcohol regularly, whether the patient has a peripheral neuropathy, whether the patient has allergy or hypersensitivity to any medications, whether the patient has pregnancy or previous history of TB. Those are not contraindications, previous history of TB or pregnancy. However, all the other rest are the contraindications. The TB preventive treatment, the target population is people living with HIV, infants less than 12 months in contact with active TB, healthcare workers in contact with tuberculosis, and other high-risk groups. So the contact of MDR TB in patients with drug-resistant TB, you have to screen the contact. If patient is symptomatic, investigate for TB. If the patient is not symptomatic, depending on the age of the patient, you ask for a TST or you ask for the X-ray. And if it is contraindicated, then defer it. If it is not, then initiate the TPT. Follow-up is required. Now, for active TB, even if they have completed the preventive treatment, completing the preventive treatment reduces the chance for getting active tuberculosis, but does not eliminate it completely. So, so these are the recommended. So now if the patient is a DRTB index, like suppose the patient has drug-resistant tuberculosis, but is sensitive to levofloxacin, then 6 months of daily levofloxacin can be given for the contact of rifampicin-resistant fluoroquinolones. Depending on the age and the body weight, the dosage is adjusted. 4 months of rifampicin daily can be given for contact of isoniazid-resistant but rifa-sensitive patients. So levoflox daily and rifampicin daily. So this can be given. Now we come to the PMDT guidelines of 2021. Here, so in 2021, first the grouping of the TB drugs was done, and in order to design the longer MDR TB regimen. So we had a group A which included all the 3 medicines, that is levoflox or moxifloxacin, bedaquiline, linezolid. So these were the most active and the most potent medications at the time to be used. Then we could add one or both medications from the group B, that is clofazimine and cycloserine or terizidone. And from group C to complete the regimen, depending on which medicines the patient could take from group A and group B, we could add the medications, that is from ethambutol, delaminate, pyrazinamide, imipenem, cilastatin or meropenem, which were injectable medications, amikacin or streptomycin, ethionamide or prothionamide, and PAS. So now there is a strong discouragement towards starting any injectable medication for the treatment of tuberculosis, whether susceptible or MDR. Streptomycin has been completely given up from the initial sensitive regimen. Earlier, there used to be a CAT2 regimen where streptomycin used to be given for relapsed patients or patients who are retreatment pulmonary tuberculosis, but that is not there anymore. There is just one treatment regimen. We will come to the treatment of drug-sensitive tuberculosis shortly. So basically, the drug-resistant TB should be referred for treatment, diagnosed early, referred early for treatment initiation, counseling, watching for adverse drug reactions, follow-up, contact tracing, post-treatment follow-up. So all these things are important. When the patient gets diagnosed, they need to be registered in NICSHE. They need to have somebody to see them for the adverse drug reaction. They need to be continuously counseled so that they don't give up on the TB treatment because of the side effects or because of any other issues, any patient, any problem for the patient like cost or distance from the center, work difficulties. They need to be financial difficulties need to be evaluated. So it is not just having the treatment. We need to do all these things. That is the lab result, the duration of treatment has to be established, the reassurance to the family against stigma, infection control precaution. It's no use to treat one family member and immediately to have the other family members to suffer from tuberculosis. Now again, after completing, we have to check with NICSHE if the LIPA results are available. So if suppose you are diagnosing rifampicin resistant, you need to check the second line DST test, first line and second line DST with the LIPA. Also do the cultures, await the sensitivity, and do also the drug sensitivity test. So with that, you can confirm the MDR-TB as well as give the best regimen in case the patient is failing the initial regimen which has been started. So we have the shorter oral bedaquiline containing regimen and the longer oral MDR or XDR TB regimen. If there is any resistance, additional or intolerance, this we will come to know by doing the additional test, that is the second line DST and the culture testing. So, and it can be replaced as per the replacement table. So what all do we need to check? We need to check the sugar, HIV testing, complete blood count, liver function test, thyroid, the urine examination, electrolytes, urine pregnancy testing, chest X-ray, ECG. So all these things need to be tested. So now we come to the new regimens, that is the shorter oral bedaquiline containing MDR-TB regimens. So this consists of 4 to 6 months of bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high-dose isoniazid, and ethionamide in the short course, 4 to 6 months, followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. So from the start to the end of the 4th month, all the drugs are there. 5th month to end of 6th month, if IP is not extended, it will be bedaquiline, levofloxacin, clofazimine, pyrazinamide, and ethambutol. So start of the 7th month to end of 9th month, we will be giving levofloxacin, clofazimine, pyrazinamide, and ethambutol. So this is based on the DST-based inclusion criteria. You have to see the rifampicin resistance is there, whether isoniazid resistance is also there, and fluoroquinolone resistance should not be there. Children less than 5 years to 18 years, and they have to be consulted with the pediatrician before starting. There should be no history of previous treatment with these second-line medications, particularly bedaquiline, levofloxacin, ethionamide, or clofazimine. So many of our patients already have exposure to levofloxacin or ethionamide treatment for more than 1 month. Then these patients are not cannot be taken under this regimen. If they have a baseline QTC prolongation, they cannot be taken. If they have additional risk factors for any tachyarrhythmias, then we need to then it gets contraindicated. See, the other exclusion criteria are the isoniazid resistance with both CATG and INHA. So then they become not eligible for ethionamide, or MDR-TB patients with fluoroquinolone or second-line injectable resistance if it is detected. So this was the, in case they are not eligible for for bedaquiline, then they can have the substitution with kanamycin or amikacin. So it will be moxifloxacin, kanamycin, ethionamide, clofazimine, pyrazinamide, isoniazid, and ethambutol. And 5 months of moxifloxacin, clofazimine, pyrazinamide, and ethambutol. So this is being followed for patients who are not eligible for taking the bedaquiline. So this was what was being followed till now. We need to do a baseline audiometry, and every 2 months for all patients on second-line injectables. Creatinine also need to be checked for patients on the injectable medications. So we have the shorter oral bedaquiline. So these are the doses and the dose range. We'll not go into detail for that. And these are all the tests which need to be done. Smear microscopy, culture, drug sensitivity testing, urine pregnancy testing, CBC, X-ray, ECG, electrolyte, specialist consultation, color vision testing once in 2 months. So this is so much in detail that the national program has gone. And for patients, what about patients with renal impairment? For isoniazid, no treatment adjustment required. Pyrazinamide, ethambutol will be thrice weekly, levofloxacin thrice weekly, moxifloxacin no adjustment, ethionamide no adjustment, bedaquiline no adjustment, and clofazimine no adjustment. Then we have the longer oral XDR regimen, that is 18 to 20 months of levofloxacin and bedaquiline, followed by linezolid, clofazimine, and cycloserine. So this is patients who are excluded from the standard bedaquiline containing regimens, including for the XDR-TB patients. So this was the longer oral regimen, but even here you need the availability of bedaquiline, which need to be tolerated for more than 6 months. We have to rule out cardiotoxicity, anemia, linezolid, all the linezolid side effects like thrombocytopenia, peripheral neuritis. Cycloserine, be careful in pre-existing seizure disorders. Remember that clofazimine causes dark brown discoloration of the skin. So these were the replacement schedules. So we'll not go so much in detail about these. So now we will come to the next guideline, that is 2022 guidelines. I would like to talk just in brief about the drug-sensitive TB. So the basic treatment for drug-sensitive TB remains the same: 4 HREZ followed by 2 HREZ followed by 4 HRE. So this is the dosage range. FDCs are preferred. And for patients with abdominal TB, intraocular TB, TB meningitis, they will need a longer course of treatment. Steroids are indicated only for the TB meningitis, not for the abdominal TB or for the, and even for the intraocular TB and meningitis, we will require to give tapering dose of steroids with the consultation review. So pediatric TB, again, note that the doses are higher, even with respect to the weight. Isoniazid dose is higher, rifampicin dose is higher compared to the dose which are recommended for the adults. The consideration for osteo TB or abdominal TB, meningitis, longer course of treatment and may require additional steroids to be given. So the newer treatment for the drug-sensitive tuberculosis is a 4-month rifampicin moxifloxacin TB treatment regime has been suggested. This may come in shortly, where we have 4 months dose given for moxifloxacin, a 4-month regimen of rifampicin and with rifampicin and moxifloxacin with pyrazinamide and ethambutol. So this will be the 4-month regimen which will be given. So this would be coming in shortly. What is the newer treatment for MDR TB? So this is the new regimens which is made the treatment of MDR TB very short. This is a new exciting regimen which has been, a lot of studies have been done which have shown that a 6-month bedaquiline, pretomanid, linezolid and moxifloxacin regimen called the BPAL-M is effective for multi-drug resistant TB, and WHO has come up with its recommendation for use of 6-month treatment composed of bedaquiline, pretomanid, linezolid and moxifloxacin rather than the 9-month or longer regimens for the MDR TB treatment. Although they have said it's a conditional recommendation, it is planned to be rolled out very soon, and more studies are on the way to get more data. The 9-month oral regimen for MDR TB has also been recommended for patients in whom resistance to fluoroquinolones has been excluded. The other treatment is so these are all the depending on the groups. So we will not go into the complete details of the differences between the 2020 updates and all the various differences in the regimen for lack of time. So this, I would refer you to this image in Nature, November 2022. So where we see that the latent TB infection is there, which goes into subclinical TB disease, going into active tuberculosis, going into acute cavitary disease. And in vitro, we have a similar growth where intracellular inside, it grows first inside the macrophages, it forms cords in the lymph nodes, the cells, and it causes the extracellular and in the neutrophils in the caseous material, it is there. And thus it causes a TB pathology where there can be drug resistance, there can be persistence of the drug within the macrophages, within the intracellular ambience, causing resistance, dormant bacilli, reactivation, drug, and making it more and more difficult to sterilize. And these are the various new drugs which are available, which make the situation of MDR TB and TB treatment much more optimistic, because there are so many regimens which are still even in beyond phase 2 and phase 3. The regimen is being developed. Already developed, delaminate, pretomanid, bedaquiline, rifampicin, moxifloxacin, sutazolate. So these drugs were not available to us 10 years ago, but now so many new drugs are available which act on various parts of the TB growth pathway. And many more drugs are also in the pipeline. And these are the various tests which are there: the BEAT TB trial, Simplicity TB trial, STREAM trials, NTB trial, Intense trial, RIFA-SHORT trial, Truncate TB. So many studies are going on, TB Trust trial with all these, with the newer drugs, and to chalk out their efficacy and side effects. So I would end on that note that yes, we can end tuberculosis. We are still far away, but with the newer drugs, with the newer regimens in place, and with a strong political will and with a strong will from the part of all of us diagnosticians and doctors, we would be able to see a world free of tuberculosis one day. Thank you very much.
Thank you, Dr. Jayalakshmi, for giving a wonderful presentation, taking us through the journey right from the Middle Ages and where we are now. I would rather emphasize one or two particular points. When certain drugs QTC interval must be taken into very much into account. You just mentioned ECG. In ECG, when you do in these patients, certain drug like the levofloxacin, moxifloxacin, even the bedaquiline, it can also increase the QTC interval. If the QTC interval is beyond a certain limit, then these drugs should be withdrawn. Number one, and number two, ethambutol will be used for longer period, and this distinction between the color red and green color as well as the visual acuity, all these things should be done right at the beginning. Other thing, even in the forget the home domiciliary treatment, even the patients who are admitted to the hospitals, if you do the checking of the medicine, how the patients are taking the medicine. So most of the time we find that many a time even the nursing staff is not giving the tuberculosis ATT properly. Sometimes the dosage are not correct, and in the sensitive cases where they are not being given empty stomach, or patient is having some meal and then having it, or dividing into many things. So all kinds of problem we do face with the tuberculosis treatment. And now some audience had raised a question that should moxifloxacin not be used for other uses. So what is your opinion about that? Except for the tuberculosis, should moxifloxacin be reserved only for the tuberculosis patients? Dr. Jayalakshmi, please.
Looking at the number of and the severity of the problem of quinolone resistance, and seeing that patients who are resistant to quinolone, they don't even become eligible for the bedaquiline containing regimens. Of course, the new BPAL regimen can be given, but even the BPAL M, which is for the MDR TB, one of the main drugs is moxifloxacin. So if we could have, although because there are so many antibiotics for other illnesses, but for tuberculosis, we only have restricted group, and tuberculosis is a big killer. It is, although we said it is second to COVID in the number of deaths. If you see per year, the number of deaths, even during the COVID, it was tuberculosis still surpassing the number of COVID deaths, particularly in India. Seeing that, I think it would be good if we could reserve quinolones as far as possible for the tuberculosis cases only, and not use it for other cases. At least we find it is being used by GPs, very randomly for small illnesses, for UTI. So this can be.
Yeah, absolutely right. I firmly believe that the moxifloxacin, one advantage we have, that we don't have to modify the dosage in the patient with the renal dysfunction. So that is very easy, one dose. And in the levofloxacin, moxifloxacin, both of these drugs we should try to not use them for any other indication. If we have any alternate, we should use those alternates. Only in the situation where you do not have any alternate, only in those kinds of situations, in a non-tuberculosis patients, one may use these drugs. And anything else anybody wants to ask, Doctor? I don't know about this BPAL regime, which has been proven successful in the XDR tuberculosis in the various trials. I don't know whether pretomanid is available in our country or not.
Not
as
yet
far as
available,
my
but
knowledge, it is not available in our country.
Not
and
yet.
bedaquiline is also available only in the certain designated center. Like in Delhi, I'm in the Delhi, there is a National Institute of Tuberculosis. In the place where I work, it is close to that place. So it is only through the hospital supply. Patient cannot go and buy it from the market. So I think that is another good thing which government is doing. However, today in the newspaper, if you might have read, that the Johnson & Johnson, which have, it is 10 years in July, are going to be over of the bedaquiline. And Johnson & Johnson wanted that their license should be continued further. So government has refused. So that, okay, 10 years are over, and now you cannot have monopoly beyond this period. So I think it is very good that the bedaquiline has been in the, it has not been fallen into the abuse and the rampant misuse. And delaminate, which has another newer agent, has come in last decade or so. Delamanid in various control trial hasn't been found to be very useful, while bedaquiline is much more useful. So in the rifampicin resistant or MDR resistant also, like Professor Jayalakshmi has shown many various regimes where the only oral regime also you can give only oral regime for the rifampicin or resistant or MDR resistant. So thank you, Dr. Jayalakshmi, for taking us on this wonderful journey of the various ATT discovery, right from the where the mummies which suffered and from the sanatorium and where the BPAL-M regime where we are. Thank you very much.
Thank you. Thank you, Dr. Mishra. Dr. Thomas is there.
Dr.
Yes.
Thomas is from Chennai, and I don't have much detail about you, but I know that you have a very keen interest in treating the tuberculosis patients, and you have been involved in the tuberculosis and various other respiratory problems and smoking cessation also. I think I was told that you are also involved in a big way in a smoking cessation program, and you shall be, I think you are presenting to us various wonderful cases of the tuberculosis, because nowadays, earlier days that it was said in the olden days when we were MBBS students, that if one knows the syphilis, you know the whole medicine. Then it was that if you know the tuberculosis, then you know the whole medicine. Then nowadays it is HIV, you know the HIV, now it is COVID also, you are seeing a lot of problems. So I shall, without wasting any time, I shall request you to show us various interesting patients and so that we can learn many more new things. Thank you, Dr. Thomas, please.
1 minute, sir.
Yeah.
Are you able to see my slides?
Yeah, you come on to the slideshow.
Okay. Yeah. Thank you, Dr. Mishra, and thank you, Dr. Jayalakshmi, for that wonderful lecture. And really, I think you've really gone through the nuts and crux of the 2022 guidelines, especially with relevance to MDR, and also looked at primary treatment of tuberculosis. I think that's wonderful to listen to you. Thank you very much. I thank IGCP for giving us this opportunity to share this platform and be with us this afternoon. What I'm going to talk today is something very light and simple, and it's not very heavy and overloaded. We are going to talk about simple cases where there is a mimic of TB, where TB is a huge mimicker, as we call that, because I think TB mimics a lot of other diseases. And I think one of the main reasons why we say that TB is a huge black box that we really open up. It's like a Pandora's box. You open and then you find a lot of things coming out of that. So Mycobacterium granulomatous infection, I don't really think we need to go into it. Prevalence of TB would be an estimated 10 million people fell in with TB. 2020, the high TB burden accounted more than 86%. We understand this. Of course, these are the symptoms. Oh my God, what's happening? These are the basic symptoms of TB that we are looking at here. We know that. I don't think we really need to go into it. We are very familiar with this as well, just to recollect. And this is what is important. We need to understand that 80% of X-rays are normal. And I think that's the most important thing that we need to look at when we look at an X-ray. Is it normal or is it abnormal? 20% are abnormal. The issue is the 20%. How you deal with the 20% deals to a great extent as to how you deal with the 80%. With the 80%, you keep quiet, and with the 20%, you go ahead and try and investigate and see what best you can do. So a normal chest X-ray occupies 80% of chest X-rays that are taken, and I think that's something that we need to understand and appreciate as such. So this is a very typical tuberculous presentation with a thin wall cavity surrounding rim of inflammation, predominantly upper lobe. You contrast this with this cavity that you see here with, this is a typical adenocarcinoma that we are looking at, thick wall cavity, irregular margin and spiculated. Please understand that the site is almost the same in these two lesions. The site doesn't really make a difference. The site makes a difference in patients with naive tuberculosis, but if you look at patients with diabetes, for example, immunosuppression, you will find tuberculous cavities all over the place. You will find lower lobe tuberculous cavities, your lobe tuberculous cavities, which are basically predominantly dependent on the lower lobe. So I think this upper lobe cavitation is very typical of patients who are naive and who have no immune suppression as such. These are the patients that you look at, and this is the differentiation of cavitation that you're looking at. So this is a common scenario that we often come in our day-to-day practice. A destroyed lung on the left, and you find that there's a huge deal of bronchiectasis, areas of bronchiectasis. There is a herniation of the right lung into the left hemithorax, and you find there is a contraction of the left hemithorax. There is always this tendency to treat this as tubercle at any point of time that we see a shadow like that. I think that is the problem as such. When you see a shadow like that, the best thing to do is to check sputum repeatedly. A very simple thing like checking sputum repeatedly will tell us whether you have a tuberculous reinfection at all or not, whether you're going to have an active tuberculous lesion that you need to talk. So I think a simple sputum smear AFB, I think, is something that needs to be stressed. However many times we do it, once, twice, thrice, 4 times, perfectly okay. There's absolutely no problem. And I think we need to understand that very clearly, that this is a very important thing that we are trying to do. The other thing that we need to do is that we need to investigate these shadows as such. You look at the X-ray on the right and look at the X-ray on X-ray on the left and the X-ray on the right. You find that over a period of time, it evolves into the shadow. All investigations are negative. So what do you do in a situation like this? You've done a ball is negative, everything is negative. What do you do? The best thing would be patient is reasonably asymptomatic for all I know. So the best thing to do, I think, is to wait for 1 month and then repeat an X-ray after 1 month. The repetition of X-rays and the look at the old X-rays, I think, are very, very key when you look at the clinical science of treating patients with tuberculosis. Now, this is 10-9-22. This is an obvious sputum positive, GeneXpert negative, HREZ-EMB. So I think that that's really not an issue at all. Look at these shadows. And I think these shadows are very interesting in the sense that the left upper lobe is filled with shadows, multiple reticulations, multiple cavitations. And you look at this and you finally find that this is an ABP and it's not tubercle. And I think that's something that you need to be careful. You can get a superimposed tuberculous infection. So in all these patients with chronic bronchiectasis and ABPA, I think it would be at every exacerbation, we need to be cautious about the fact and consider tubercle as an alternative in these patients to see that you really pin down the diagnosis of ABPA and don't miss tuberculosis in the middle. You look at these 2 months, the 7th month and the 11th month in these X-rays as such, and you find that they are progressive. And I think this is just to show that you need to chase your X-rays. And I think that's what I was taught in medical school. You need to chase your X-rays, especially when you're not sure. Please go back on the old X-ray or chase the X-ray, get an X-ray done, and you'll find that there is cavitation, sputum positivity, and the diagnosis of tuberculosis is quite obvious. Please don't be satisfied with one single X-ray over a period of time, and make sure that you repeat X-rays as often as is necessary to really attend to situations and situations like this. Now, this is not rocket science. This is pretty easy. Miliary tuberculosis is something that we've often looked at. You look at an X-ray, there's a very, very strong possibility that you will miss a miliary CT. So if you're really thinking about a miliary CT, please look at a CT scan, because the CT will be much more productive as far as the miliary shadows are concerned. The picture will be more clear. The picture will be better. The picture will be more clinically normal, clinical to us. So I think it is important that whenever you suspect miliary tubercle, always look at the fact as to whether you need a CT at all in this place at all or not. So you rule out all these things, you rule out fungus, you rule out CA, all these things. I think these are important when you look at miliary TB. A pleural effusion is something that we've dealt with for a very long time. Accumulation of fluid at the pleural space, delayed hypersensitivity reaction. So tuberculous pleural effusion is being the second commonest type of existent tuberculosis and makes up for 5% of the Mycobacterium infection. The very, very common type of infection in patients who are who have subclinical immunity in these patients who develop tuberculous pleural effusion. An effusion in this country, if it is unilateral, and if it's not accompanied by comorbids, is tuberculous unless proved otherwise. But I think today we have tests by which we can prove that the tubercle much better rather than going for the old cell count. And you have things like ADA, you have a gene expert which will tell you very clearly whether you're dealing with tubercle at all or not. So it is very, very necessary to exercise our constraint and look at these things as such. So this is tuberculosis of the pleura. You find that on examination, obvious reduction of chest wall expansion due to the collection of fluid on one side. You look at the blood parameters, look at the ESR, look at the other parameters that you really need to look at. The total protein is 5.9, which makes it an exudate. Your sputum AFB, which is negative, a gene expert, which is positive, a creatinine and no growth. And I think that points towards a tuberculous infection. So in a tuberculous infection, I think it's important to look at two things. One, it's important to look at the biochemistry. It's also very because you need to get an exudative and a lymphocytic effusion. And then, of course, today you have things like the gene expert and the ADA, for example, which can really point towards the presence of tuberculosis in this. Standard anti-tuberculosis treatment consists of 2 months of treatment. We've already seen that. Dr. Jayalakshmi has dealt with it extensively. 4 oral drugs in the intensive phase, which were rifampicin, ethambutol, and pyrazinamide. And then, of course, the maintenance of 3 drugs, which are isoniazid, rifampicin, and ethambutol. Pyridoxine supplementation was given. Now, this is a common occurrence that we get here today, especially in patients with burnt out tubercle. You have a pleural calcification, which can be mistaken for active tuberculosis, can be mistaken for active bronchiectasis even. So I think it is better that you think about this as a condition before you get into these types of things. You do a CT and you'll get a nice picture in these sort of situations. So the pleural thickening is something that we need to understand. Pleural thickening can be assessed by the fact that the left heart border becomes obliterated. You're not able to see the left heart border, especially at the bottom, where on top you can see the left heart border. Cervical adenitis is something that is, again, very, very common in patients that present to us. Cervical adenitis, I think it's a huge fancy in situations to put in a needle and do an FNAC. But the point is that by doing an FNAC, in a caseous tuberculous node, you'll be producing a sinus and opening that node, and you will have the so-called cold abscess that we studied in surgery as such. You have multiple cold abscesses. So the best thing for a tuberculous node would be to do a wedge biopsy or an excision biopsy if it's possible, where you take off the node, make sure that you get a diagnosis, usually get a huge chunk, whereas if you do an FNAC, you probably will get just a couple of cells and nothing else. So it's important for us to understand that all tuberculous nodes, the first investigation of choice is to do an excision biopsy or a wedge biopsy and get the node. If you do a wedge biopsy, you will not have anything like a cold abscess that is sticking out of it, because it will drain and it'll close by secondary intention, and there won't really be a problem in these patients as such. So tuberculous lymphadenitis is something that where we need to be very cautious. It's become extremely common in this country to really look at tuberculous lymphadenitis and treat it properly, because it's one of those wonderfully easily treatable conditions which can be treated over a period of time. ESR will be elevated, the total count may or may not be elevated. Differential count, standard anti-tuberculosis treatment, 2 months of rifampicin, 2 months of 4 drugs followed by 3 drugs for the next 4 months. Oral pyridoxine supplementation was added through the course. Tuberculous enteritis, for example. You look at the colon, tuberculous colitis, and I think that's again a problem. We understand that tubercle can infect every part of the body or any part of the body for that matter. And we understand also that it can affect the colon. However, it did not experience any altered bowel habits. This is the patient who was a 64-year-old male, history of weight loss and loss of appetite, vital signs stable, mildly distended abdomen with a positive negative fluid thrill, localized mass palpable in the right iliac fossa. And that's the pointer to us to look at these tuberculous nodes as such hemoglobin in these values. Then you do a colonoscopy and you find a nice tuberculous node that's really present here, caseating tuberculous lesion. You take a biopsy from that. Now, these things are very gratifying to treat, and I think that's the most important thing. You pick up a right iliac fossa mass, then go in and do a colonoscopy, get a biopsy, get a final diagnosis. I think it's wonderful to treat these patients because they have almost complete 100% remission, and there will be no problem in these patients at all. So I think it is important that you detect tubercle in the first place, that you suspect tubercle in the first place, detect tubercle by whatever means that's possible, whether by doing a smear or doing a gene expert or doing an ADA if it's a fluid, or doing anything for that matter to really confirm the fact, to a culture even for that matter, be it an LJ culture or be it an MJIT culture or be it LPA, whatever. You do a culture where you confirm the diagnosis, because tuberculosis is an entity that in this country should not be missed. It should always be suspected because it can be treated wonderfully. So I think anti-tuberculosis treatment initiated in this patient produced tremendous success. He was completely free from his symptoms. And I think we need to understand that. So nervous system, I think, is another thing where tubercle is sometimes present. Is often the presentation is with fever, headache, vomiting, malaise, seizure, and cranial nerve paralysis and abnormal mental status. CNS TB is associated with significant mortality. Etiology suggestive CSF findings should be taken into consideration before you start anti-tuberculosis treatment. So the CSF is the gateway to diagnosing neurologic problems that are associated with the central nervous system. And I think this is something that we need to understand. Adjuvant steroid therapy is something which is very commonly given in patients with neural tuberculosis for that matter. Previously, we were using steroids for even pleural effusion, but today we very rarely use them in situations of pleural effusion because the drugs are so very effective that the additional use of steroids are really not necessary in these patients as such. Ultimately, I think what one needs to understand is that the index of suspicion, I think, is the most important thing. Suspect tubercle, and if you suspect tubercle, try and chase the tubercle. Do a repeat X-ray, do a gene expert, do a simple smear for AFP, which I think many times we fail to do, and we are up against the wall against it. And then go in for the more sophisticated investigations like gene expert and the rest of those things. So tubercle is an easy thing to detect. It's an easy thing to treat. There is no question about it. But at the back of this all, one needs to clearly understand that the knowledge of what to do things is very important. And the eye does not see what the mind does not know. Thank you very much for the patient listening.
Thank you, Professor Thomas, for showing us various interesting cases, various interesting X-rays and the CT finding and the colonoscopic finding also. And however, I do not agree with one point that FNSC will create the formation of the sinus or the tract.
Okay.
And FNSC is a patient usually agrees to FNSC easily, while patients agreeing to wedge biopsy or excisional biopsy may not be, it may more expensive. Many patients may not agree. Secondly, FNSC can be done as an OPD procedure. Only problem is FNSC, you get something positive, you take it as. You do not get negative result, does not rule out the disease. So I think we do not feel now the sinus or tract formation nowadays that much. And another thing I would rather, which I am seeing, it is the other mycobacterium which are involved. Mycobacterium scrofulaceum, Mycobacterium avium intracellulare. So different mycobacterium besides the
Atypical mycobacteria,
tuberculosis are involved.
yeah. I agree.
Secondly, the treatment of the ATT, duration of the treatment in cervical adenitis, I think, is longer than the usual pulmonary tuberculosis. And then other thing, nowadays in my clinical practice, I am seeing a lot various ileocecal tuberculosis. However, the number of the patients coming with the tuberculosis ascites has fallen significantly down. We get a large number of patients with, and here again the confusion whether it is enteric or tuberculous, and then you have to rule out malignancy also if it is eccentric lesion, etc. So that we are seeing a large number of patients. As cervical adenitis, again we are seeing a large number of patients, and besides that, we are all seeing the retroperitoneal lymphadenitis, mesenteric lymphadenitis, hilar-red lymphadenitis, where the confusion whether tuberculosis, sarcoidosis. So anyway, you have shown us a large number of the very interesting cases, and you have also shown that tuberculosis is a good mimic, and many other conditions like you've shown the bronchopulmonary aspergillosis. So one should not forget all those things. And however, in a country like ours, tuberculosis must be excluded. We must give the proper treatment and end it. So that was thank you very much for showing us very interesting cases. Some questions have come to me. One question has come to me that the genes involved in INH resistance. So Dr. Professor Jayalakshmi, do you want to take that question?
Yeah, I have actually answered it in the chat itself. So it is like CAT-G and INH-A. So these are the genes.
Yeah.
So CAT-G gives
absolutely. CAT-G is involved in 90% cases, INH-A in 10%. With INH-A, you can give the high dose INH also. However, these patients will be resistant to ethanolamide. So I think any other questions for us? Any other questions from audience?
Yes, sir, I have posted the question. You can see, sir, the another question is, what are the newer rapid diagnostic tests for TB, tuberculosis?
I think Dr. Professor Jayalakshmi has explained all those tests in great details, how to do various flow diagram, various tests. So, Professor Jayalakshmi, do you want to give again tell them?
Yeah, so basically we have the Gene Expert and Gene Expert Ultra, which is very rapid and easily available tests. The TrueNat detection tests are also there. Then the LIPA tests are there, where we have the first line and second line, which are cartridge based or strip based tests for diagnosis. So these are give immediate results. Now even BD has come up with their own for isoniazid and RIFA resistance. Then there are the newer polymerase chain reaction based lot of tests where you have the gene sequencing, pyrosequencing, where we get the particular sequence of genes in the TB. Those are detected with the test by amplifying them. So it's all similar to the Gene Expert, but going on in a more detailed manner and giving more information. So these.
Yes. Absolutely right. Absolutely right. However, while doing the PCR, it detects the dead bacteria also. One must be careful. While using this test, one should know what they are looking for. Anyway, Any other question for us? I think both the
question is there, sir. One more question for patient TB patient under treatment and then develop MDR TB. Is it possible to differentiate between acquiring new MDR TB bacteria from emerging the old one?
So we can actually find out by seeing the gene sequencing. So if we have the gene sequencing of the earlier one and the patient is developing MDR, we can know that it is the similar, or whether the patient has acquired the MDR TB from another patient, or it's a new infection. That we can find out if we have the earlier gene sequencing.
And let us not forget, we should also take history, whether the patient has been taking the medicines properly in proper dosage, whether they have been defaulting on that taken for 2 days, not taken for 3 days. If they take medicine for a month and they do not take all medicine for a couple of days, heaven will not fall. But they take 1 thing, 2 things, 3 things, then not taking for many days. Any habit, if the patient, that kind of history you get, then you can know whatever the bacteria is there, it has developed resistance. Or in a country like ours, like Professor Jayalakshmi has already mentioned, you can always pick up anything. Another thing, Professor Jayalakshmi, I wanted to ask you, in your preventive tuberculosis treatment, you have mentioned about the healthcare worker coming in contact with the tuberculosis patient. We come in contact with tuberculosis patient every day, every single day. Though we try to screen out the positive cases in a negative pressure chamber room, 1 or 2 room in our hospital we have, or we send them off, or we send them to National Institute of Tuberculosis. Again, everybody is reluctant. Family member, they also don't want to take them home because they say we have a small children and we are living in small houses, small flats. So all kinds of problems are there. So I do not know whether all the healthcare people, healthcare workers should take the preventive treatment for tuberculosis. Your take.
So my take is that we try to, of course, wear the mask and have some protection. But otherwise, since there is a continuous exposure, it would not be practical to have a tuberculosis.
Yeah, we cannot. Yeah, Professor Thomas, do you want to have any opinion about this thing?
No, I don't really think, apart from the mask, you can do anything for healthcare workers.
And I have another in my MBBS days. We had our TV hospital was separate hospital where the surgery also was done, and talking about the late 70s in Kanpur Medical College. So professor, our teachers, they will ask whether have you taken a full breakfast? Have you taken people who are eaten egg? Have you taken 2 eggs omelette or 4 or 5 toast with butter and milk and fruits and everything? Anybody who mentioned that he has skipped the breakfast, they will just throw them out. You get out of the hospital, do not enter the hospital. So idea is to build the good resistance, good immunity. So you have to have a good diet, good exercise, and only then your natural immunity will be good. Otherwise, how long you cannot indefinitely take preventive treatment. And here I think I shall thank both of our learned speakers. I have also learned many things from both of you. Thank you very much. And I shall thank IGCP also for providing this platform. And I am sorry, my laptop conked up, camera wasn't working. So anyway, it was a wonderful experience. And I think we can do again, we can again do the structured program where we can discuss the things in much more detail. But then structured program and many 3-4 speakers can be involved. Anyway, thank you very much. Thank you both of you, Professor Jayalakshmi, Professor Thomas. Thank you. And thank you for us. And IGCP people.
Yeah, thank you so much, everyone. It was a really interactive session, and hope to see you again with different topic. And it was really relevant one. And I hope all the participants who have watched this session going to help their practice also. And till then, take care of yourself. We are closing here. Thank you so much, sir.